Side effects: menstrual, Depo-Provera, oligomenorrhea is common. More than 50% have amenorrhea after 1 year, prolonged irregular bleeding during the initial cycles, dysmenorrhea reduced, premenstrual syndrome may improve. Body weight: 70% gain weight on DMPA, 10% show no change in weight, 20 to 25% lose weight. Weight gain appears to be due to deposition of fat rather than fluid retention. Limits acceptability in Western countries. Emergency contraception: establish time of UPSI. Ask about her routine contraception method. When was her last LMP? Was sex consensual? Past medical history. Do general physical examination. Counsel about available methods. 2 are hormonal and 1 is non-hormonal. Oral emergency contraception is more accessible but only 85% effective up to 120 hours after intercourse and may have little or no effect once ovulation has occurred. Where possible, women should commence their long-term contraceptive method of choice at the time of requesting emergency contraception or a bridging method supplied until this can be initiated. LNG, levonorgestrel, mode of action: unknown but thought to act by inhibiting, delaying ovulation. It prevents follicular rupture. Dose: single dose of 1.5 mg stat. If vomiting occurs in 2 hours, dose should be repeated. Efficacy: very effective if given within 72 hours of UPSI. It can be taken up to 96 hours after UPSI, but limited evidence of efficacy. It can be taken more than once in a cycle. If BMI is greater than 26 or weight is greater than 70 kg, double dose, that is 3 mg should be given. In epileptics, give 3 mg dose. Ulipristal acetate, a selective progesterone receptor modulator. Mode of action: inhibition or delay of ovulation. It can prevent ovulation after LH surge has started. Efficacy: 1 tablet should be taken as soon as possible after UPSI. No later than 120 hours. Can be taken multiple times in a cycle. Repeat dose if vomiting occurs within 3 hours of taking it. If patient is on CHC, then barrier contraception has to be used until withdrawal bleed or next period. Contraindications: hypersensitivity to its constituents, severe hepatic impairment, severe asthma. Breastfeeding should be avoided for 7 days. Side effects: abdominal pain and menstrual disorders like PMS, uterine cramps and irregular vaginal bleeding. Drug interactions: liver enzyme indicators like ritonavir, carbamazepine, phenytoin, rifampicin, St. John's wort may reduce efficacy. Concurrent use of antacids, H2 receptor blockers like cimetidine and proton pump inhibitors decrease absorption of ulipristal acetate or UPA. Barrier contraception. Advice to take additional measures as UPA binds to progesterone receptors. If taking COCP, use additional methods for 14 days. If POP, 9 days. QLERA, 16 days. Record keeping in relation to emergency contraception is also very important to counter complaints or subsequent litigation if the method fails. Young women under 16 years should be fully assessed to determine the existence of unidentified safeguarding concerns, including child sexual exploitation. IUD. Most effective emergency contraception method can be inserted up to 5 days after UPSI or unprotected sexual intercourse. In a patient having regular cycles, it can be inserted if patient is within 5 days of expected ovulation. Failure rate is 1%. A copper IUD is 99% effective up to 120 hours after intercourse and should be offered to all women requesting emergency contraception. IUD can be used if multiple episodes of UPSI. A pregnancy test should be done after 3 weeks. Decision-making algorithms for emergency contraception. Algorithm 1. Decision-making algorithm for emergency contraception. Copper intrauterine device or oral emergency contraception. Currently less than 120 hours since last UPSI. In case of yes, no and unknown. Yes or unknown. No. Yes. No or unknown. Yes. No or unknown. Yes, no or unknown. For choice of oral emergency contraception, see the next algorithm. Algorithm 2. Decision-making algorithm for oral emergency contraception. Levonorgestrel emergency contraception or LNG EC versus ulipristal acetate emergency contraception. Yes, no or unknown. Please note that oral emergency contraception is unlikely to be effective if taken after ovulation. Sterilization. Sterilization is the principal method of contraception used worldwide, with an estimated 190 million women and 42 million men having undergone the procedure. In Europe, 44% of women aged 45 to 49 years were using sterilization as their method of contraception. Traditionally, this has been performed by laparoscopic tubal occlusion. However, hysteroscopic procedures are becoming increasingly popular. Assure was recently withdrawn in the UK on commercial grounds. Sterilization provides excellent long-term and permanent contraception. However, great care has to be taken to ensure that individuals and couples are counseled appropriately and they have fully understood the implications of the procedure. Alternative LARC methods, which are more effective, subdermal implants and progestogen releasing IUS, must be considered. The risks and the benefits of both male and female sterilizations discussed. The couple should be carefully and individually counseled and appear certain of their decision, with detailed written consent obtained prior to the procedure during being performed. Sterilization is declining in popularity in developed countries, probably due to the increasing adoption of long-acting reversible contraceptive methods. Female sterilization can be performed laparoscopically or without general anesthesia via hysteroscope. Adequate counseling and consent are required to minimize the incidence of regret and requests for reversal.